Thanks very much, and thanks for joining us online and here in person. I'm going to go first before Kate to try to give you an idea of some of the work that we've done at Hopkins that sets up the kind of intervention that Kate's working on, and give you an idea of why we've been working together on that. And I'm going to focus on findings that come from our own center, the Center for Childhood Asthma in the Urban Environment. I want to start by telling you about a boy that is in one of our studies. And when we met him, he was 10 years old. He's African American and lives in East Baltimore, which is where Hopkins is located. Household income was low, and he's very symptomatic. So in a 2-week period, he'd had 4 days with symptoms. He'd woken up 2 nights. And in the past 3 months, he'd had 4 unscheduled doctor visits for his asthma. He's on a whole host of medications, and most of the ones that we know to prescribe, albuterol, an inhaled steroid, a leukotriene modifier, and then also systemic steroids. And in his home, he had, among other things, an active smoker, cockroaches, and mice. And so he's in a lot of ways is typical of the people we have in mind for our studies. I'll point out here, this is a graph from the CDC, and the circle is 1998, because that's when he was born, so we met him in 2008. And he was born in the midst of an epidemic that's been increasing and continues to increase beyond the length of this figure. The figure's split because the CDC changed the questions that they ask in 1998, coincidentally, when he was born. But what you can see is both for children and adults that there's been a rise over time and in a relatively short amount of time. What's important also is that we see this is about the same time scale as the prior slide. And one of the things we can see here, too, this shows mortality over a time scale. And there's been some attenuation of mortality, which is good over the last several years. But the gap between mortality for whites and blacks has actually increased, even though there's attenuation overall. And this is true for other outcomes, too, hospitalizations, symptoms, and other things that are important. So this has been our focus, is to try to identify factors that contribute to this disparity and also to try to eliminate them. And I'm representing a group called the Center for Childhood Asthma in the Urban Environment, which is funded by NIH, the Environmental Health Sciences Branch, and EPA jointly. We're in our third 5-year funding period, so we've had this center for more than 12 years, initially led by Peyton Eggleston and now led by Pat Bricey of School of Public Health and myself from the School of Medicine. This is a model that started the center, and it still guides us now, which is that we're really looking at complex interactions between factors that can bring on asthma or make it worse. We focused on pollutants and allergens, and we focus on ones that originate or congregate inside the house. We look at the steps that lead to immunologic sensitization, that lead to symptoms. And what you see on the bottom there also is that, and for you online, I'll just show you, if I can get this down here, that we don't look at this in a vacuum. We look at it in the context of where people live and how they live, and recognizing that asthma, as with most chronic conditions, is not just the disease, but also related to the susceptibility factors that are contextual. This is a picture of our laboratory. You know, some people have an actual laboratory to study. I don't, and this is what we consider to be our laboratory, which is a picture of a typical block in East Baltimore. And what you can see is that although the housing structure differs from neighborhood to neighborhood, that what's very typical is 2 or 3 story row homes that are turn of the prior century in terms of when they were built, and that there are many that are occupied that are also adjacent to unoccupied houses as well. So I'm going to address just three of the points that I think we make with our center, just to give you some highlights of things that we've worked on that I think set up, I hope, nicely for Kate, the intervention that she's working on. And one finding about whether or not domestic mouse allergen causes asthma morbidity. So do mice in the house make asthma worse? Do the pollutants, particulate matter and nitrogen dioxide, do they make asthma worse? And then the third point is, can we intervene? What's available to do right now? So with this first point about mouse allergen, so that's not a mouse, right? That's a cockroach. And before I talk about mice, I just want to bring us back for a second. We've known more about cockroaches longer than we have about mice in terms of what they do in the house. And it's a story that's been known for a while. This is a poster made by our Community Advisory Board in connection with the Maryland Institute College of Art. And there's a few posters they made, which I think are really nice, but illustrating some factors that affect asthma. The reason I'm showing the cockroach, though, is I just want to explain the working model for what an allergen does and why it makes sense to study it the way we do. So this is a little bit of a complicated slide, but not too bad if you take a moment here. The point I want to make here is that there's 2 steps to becoming a person who's allergic to an allergen. And the first step is illustrated at the top here, where the allergens, which are those little green dots, they come in and they meet certain kinds of white blood cells. Those white blood cells communicate. And you see over on the right-hand side of the slide that B cells, which are a lymphocyte, they put out antibodies as a response. And those antibodies are those little upside-down Y things, the yellow. And they go and attach to other cells, in this case mast cells. Once they've attached, that's now a sensitized cell. So that step has to occur first. First, the cells become sensitized. And then the second step is now you're re-exposed to that allergen, and that causes symptoms. So 2 steps have to occur. First, sensitization, and then second, re-exposure to the allergen. Reason that's important is because this is a cockroach finding, and this is a study that was published over a decade ago from the National Cooperative Inner-City Asthma Study. And this showed very convincingly that cockroaches matter in terms of asthma morbidity. So this illustrates hospitalizations in kids with asthma. And there's 4 bars there, and the first 2 blue bars are non-sensitized. So these are kids who have not had that first step of sensitization to cockroach. And the first bar is low exposure, and the second bar is high exposure to cockroach. And you can see they have a similar amount of hospitalization. The next bar is sensitized but not highly exposed, and that also is similar. So they don't have that second condition of high exposure. But when the 2 are together, there's been both sensitization and exposure. That's when you get the morbidity. So this is sort of the working model for allergen-provoking asthma, and it's the same model that we use to look at for mice. So in one of our studies, we recruited preschool-age children, so 2 to 6 years old. They were all in 9 contiguous zip codes in Baltimore City. They had to have health care doctor-diagnosed asthma and have active asthma within the last 12 months. We also recruited controls who were very similar, except they didn't have doctor-diagnosed asthma or symptoms. This is a map of Baltimore City, and it's a partial map, but there's some things you can see on here. I'll use the cursor, but this is where we are right now. This is Johns Hopkins Hospital and Johns Hopkins School of Public Health are on this intersection. My cursor disappeared, but this green plus. And you can see that the red dots are people with asthma, and the triangles are controls, people without asthma. And we use this sort of northeast quadrant, if you will, of what's defined as East Baltimore to do our studies. We spent a fair amount of time assessing what their indoor environment was like. So we sampled particulate matter, which I'll talk more about in a little bit. We sampled dust from the bedroom and the kitchen and the family and TV room to look for allergens. We had a home inspection, and we also asked parents or caregivers about the life history of the child in terms of exposures that they might have had. And I'm only going to show just a couple of findings on here that are relevant to mouse. But one is that I thought was very interesting is just in terms of self-reported exposure. There's a lot of awareness of mice. You can see the majority of parents or caregivers said, yes, indeed, we have mouse exposure in our home. It's a higher bar than cockroach, so cockroach is high, and those are both higher than pets. So mice and cockroaches matter a lot. Smoking's on there too, and it's about 58%, which is remarkable and startling, given that there's the average in the country is about 21% for all comers. So in our city, in homes with asthmatics, we have more than half with a smoker. So one of the things that we assayed from the dust was a protein that comes from mice. It's found in their urine, so anywhere that mice go, you can find this particular protein. And it's thought to be a pheromone-binding protein, so some way to attract a mate. And it's a light enough particle, unlike some, that it can become aerosolized or airborne, so it can float around and be in the breathing zone, whether or not it's in the settled dust or in the air. And what we found was a parallel story to what has already been shown for cockroach, which is this is looking at rescue medication use, so the number of days of medication, 3 particular time points. And the first 2 bars in each of those 3 collections of bars are the non-sensitized kids with low and high exposure. The right-hand 2 are sensitized, low and high. And you can see that the most prominent bar in each case is those that are both sensitized and highly exposed to mouse. And we found this for a variety of symptoms as well. This illustrates using albuterol as a rescue. We also, in a longitudinal model where we looked over time, we could find that unscheduled doctor visits, ED visits, and hospitalizations were all importantly and significantly associated with being both highly exposed and sensitized to mouse. And in this case, the hospitalization odds ratio was nearly 70, meaning it was just a remarkably strong risk factor. And this is after adjustment for other things, including cockroach. So we found this to be a very important finding for us, which is at least in Baltimore City, that there's a lot of mice and that there's a very important impact of them. So this other issue I want to address is whether or not certain pollutants that are inside the home can aggravate asthma. And many of you may be familiar with particulate matter, but in case you're not, I just want to show you that particulate matter is basically dust, and it's dust that's small enough, in the case where we study it, small enough to enter the respiratory tract. It can come from natural things, so it's part of just dust that's from dirt and things out in the world. It includes viruses and bacteria, animal debris, and then there's man-made sources too. So mostly from combustion, so trucks, buses, cars, factories, and then inside tobacco smoke and anything that burns produces particulate matter. I want to give you an idea of what particulate matter looks like because you can't really see it up close. We're talking about something that's a tiny fraction of the width of a human hair, so you can't see it up close, but you can see what it looks like from a distance. And this is a slide from a camera that's mounted near Boston, and it shows what the PM2.5 concentration was in about the 10 range. And it's micrograms per meter cubed, but the thing just to keep in mind as I talk is just that number 10, because I'm going to use the same units in a couple other slides. So that's the Skyline when it's 10. This is the Skyline when it's about 60. It's a couple days apart, and it's the same vantage point, but what you can see is if you step back from pollution, you can see it better. So remember those numbers 10 and 60. So when we found, this is what we found for in our homes, and this is the distribution of particulate matter in children's bedrooms in East Baltimore. And the first two box and whisker plots here I'll spend most of the time on. This is fine particulate matter, which is what I illustrated in the other the preceding slides. You can see the range here is from 0 to 100, and we've excluded the outliers. So remember I showed you 10 and 60. The range I'm showing you here goes up to 100, but our outliers go up into the hundreds, so about 300 or so. And what you can see is that the median value for indoor fine PM, that first box and whisker, is about 35 or so. So it's sort of midway between those two slides that I showed you. And what's really remarkable is that that it's much, much higher than the outside air. So if you have an impression about what outside air is in a city like Baltimore, it may not be ideal on most days, but you can see that red line is the EPA standard in place at the time that we did the study. And because it's a box and whisker, that heavy horizontal bar is the median, the box around it. Let's see if I can make my cursor show you. I can't get the cursor to come on. But the box around it shows the interquartile range. So what you can see is the ambient air would only fail the EPA standard about a quarter of the time. But the homes would fail, if there were such a standard, would fail about 3/4 of the time. So much, much worse inside than outside in terms of particulate matter. Nitrogen dioxide is another pollutant we're interested in, and this is a gas that's produced by combustion. And just a lot of the sources are the same. So if you burn something inside, or if you use natural gas for cooking or a gas heater, things of that sort will produce it. It also comes from smoke and from exhaust from cars, trucks, and buses. The problem with it is it can damage the airway epithelium. There's evidence that it can increase susceptibility to infections, and it can promote sensitization to allergens as well. So this is another figure I want to show you, and it shows a couple of things. So the ambient values of NO2 on the vertical axis or the y-axis, and indoor NO2 on the x-axis. And two things to notice about this. One is that there is no relationship between the indoor and the outdoor. And this was important for us. This is a swirl of dots that seem to have it's not a straight line, it's a swirl of dots. And I do know that sometimes people will produce a swirl of dots and they'll shoot a line through it and try to convince you there's a relationship. I'm hoping you don't see one. The R squared is 0.015, which is really no association. The reason this is important is because you could say that maybe the NO2 you measure inside a home just came in through the window, and some certainly does, but it's not mostly that. There's an indoor contribution that matters. If you look at the range also, the ambient range that we had goes up to 50, and the indoor range goes up to 300. So it's another example of where we actually have a higher pollutant concentration inside than we do outside. So what's the impact? A couple things here. So we looked at it a bunch of different ways and adjusted for a variety of things, but in most of our models we adjusted the indoor for ambient or outdoor values. And what we can find is for most of the common asthma symptoms that there's a significant increase in those symptoms for every 10 micrograms per meter cubed. So remember my slide, the range I showed you was 100. Our actual range goes up to 300, and the difference in the skylines was about a 50-point difference. So for every 10 micrograms per meter cubed, we could find an important and significant increase in symptoms and rescue medication use. And the same story for NO2, and this is after adjustment for particulate matter. So the two contribute in some way separately to the symptoms, and we can find significant symptoms in either case. So the last thing I want to talk about before handing over to Kate is can we intervene? And here, this is an emerging story that we're trying to contribute to. And one of the things I want to mention first is what's already known about this in terms of what the guidelines recommend. So this is a slide that reproduces recommendations for asthma healthcare practitioners from National Heart, Lung, and Blood Institute. And this is consensus and evidence-based guidelines based on what's known. And so we know that for allergens, it says that if a patient has asthma, we should reduce, if possible, exposure to the allergens. But the second bullet point is especially important, that to know that you can't just pick one. You have to have a multimodal intervention for it to work. And the evidence grade is A, which means that there's been a number of randomized controlled trials in the appropriate population to support that evidence. So we know that. That's one thing. And that comes from studies like this. This is one of the NIH-funded multi-site studies that was done, published in 2004, where they targeted allergens and secondhand smoke in a one-year intervention. They dropped cockroach by 70%, the allergen, and also had a drop in dust mite concentration. What I want to show you with the figure, though, which is really important, is that there's this vertical bar here that you see at 12 months. That's the end of the intervention time. And so to the left of that dotted line is the year of the intervention, and the blue line is the control group. The intervention group is the orange line. And what you can see is that there's a separation between the lines and a lower number of symptoms in the people in the intervention. So the magnitude of that difference is about the exact same magnitude as what you see in a typical inhaled corticosteroid trial. So medications that we use regularly produce about the same effect as does this intervention. That's one important point. The other is that unlike medications, the time to the right of that bar is the follow-up year when there was no more intervention, and you can see that the separation remains for the entire year. So it's really a good prolonged effect of an intervention that takes 1 year to put in place, but it has a tail to it, which is quite good. This is multimodal, and it worked. But talking about the irritants in particular, which I think are an issue, tobacco smoke and then the pollutants that I mentioned, the particulate matter and NO2 and some of the others. This is another of the slides from our community advisory board, thinking about tobacco smoke. I want to show you what the guidelines say about these sorts of things. So this, I think, is remarkable each time I see it. So in terms of tobacco, it would seem to be a pretty easy recommendation to say anybody who has asthma, or especially a kid has asthma, don't smoke around them. And it makes good logical sense. But if you look at the evidence grade from the guidelines, it says clinicians should advise persons who have asthma not to smoke or be exposed to environmental tobacco smoke. Evidence grade C, so it only comes from observational studies, not from clinical trials. So it's a pretty weak recommendation for something that I think would have seemed obvious. And then consider referring to smoking cessation, a little better evidence grade, but that's for adults who smoke and have young children. So not the strongest evidence grade for that. Also, in terms of devices that you might think about, these are almost all labeled as opinion-based because there weren't trials to support them. Air conditioning gets an evidence grade C because there's an observational study that showed that people who live in neighborhoods where there are more air conditioners seem to have less asthma. That's the standard of evidence. If you look at the bottom one, air cleaners, which can strain the air of particles and perhaps of gases, they said at the time of the most recent guidelines there's insufficient evidence to recommend them, but they might reduce some allergens. They don't comment on whether they reduce pollutants. So it's a pretty weak standard of evidence. And this one especially makes me wonder where we are in terms of the progress. It says for indoor and outdoor pollution, clinicians should advise patients to avoid, if possible, so not definitely, but if possible, exposure to gas stoves and appliances that are not vented to the outside, fumes from wood-burning appliances or fireplace sprays or strong odors. So there's a sort of lumping together of these exposures that might aggravate asthma, but we don't have strong evidence to say that if you intervene that it's going to work. The guidelines also say, by the way, to come inside when it's polluted outside, and that might not work if you remember the slide I showed a few ago, because there's more pollution of some sorts inside than there is outside. So, what's been done for this? I wanted to highlight some of the findings from my colleagues in the center. This is Peyton Eggleston was the lead investigator on this study, and this was 100 children in Baltimore, randomized controlled trial of 2 groups, and it was again a multimodal intervention where it targeted allergens and pollutants. But there were only 2 things that could have affected particulate matter in this case. One was the use of a HEPA-containing air cleaner, and the other was trying to get people to not smoke. The latter didn't work. People smoked just as much before and after. So the only really thing that happened during the trial was that people had a HEPA air cleaner in the active group. And then the control group was maintained the way they were, but then treated at the end of the year the same way as the active group. They were followed over time. And so one of the things that Peyton was able to show is that the 2 lines in the lower part show between a 30 and 40% reduction in particulate matter from having an air cleaner in the child's bedroom. And that was sustained. The timeline goes to 6 and 12 months. The control group, it looks like it goes up a little teeny bit, but it's pretty much no change for the most part in the control group. So it showed that an air cleaner intervention as part of a multimodal intervention can reduce particulate matter. And this is the change in the proportion with symptoms. And you can see that there's a good change. Going down is good on this figure, so that in the treatment group, symptoms were less. Although by the end of a year, the effect was attenuated somewhat. So it wasn't, it was still significant, though. And so showing there's some correspondence between PM going down in a multimodal trial and getting better. This is a picture of one of the air cleaners from the study, and I think I like it a lot because it just, I think it's naive to think that the answer to asthma is to go plug an air cleaner in. There's a lot going on in someone's home, and it's not just that, but it can be a valuable contributor to it. Then one other study, which is just very recently completed and reported with Arlene Butts, who's in the School of Nursing as the lead. This was focused on tobacco smoke. This has 3 study groups, and there's a control group which had asthma education, and then 2 that included air cleaners. One was with air cleaners, 2 put in the house, and the other was an air cleaner intervention plus a health coach to see if a coach that goes in to help get people to quit smoking or smoke outside could work as well. And I'll just tell you a couple things about this. One is that the health coach didn't help, so there really was no impact of that, but the air cleaners did work. And this is one figure showing the control group where you see PM 2.5 concentration. That median bar on the left in the control group is at about 0, meaning that in the ones without air cleaners, their particulate matter stayed about the same. The air cleaner groups, though, it did go down, and it went down significantly and importantly. And I'll show you the actual numbers on that on this slide. So if we look at this, there's baseline and then follow-up and then difference here. But this value here, 3.5, the PM 2.5 went up by 3.5 micrograms per meter cubed in the control group, and it went down by about 20 and 16 in the 2 air cleaner groups, which was statistically significant. So 20 micrograms per meter cubed is an important difference. And this is coarse particles in the lower part of the table, and that also there was an important difference. One thing I do want to point out here is if we look at air nicotine, I can't get this cursor to work over, but in the control group, the difference is minus 0.4 micrograms per meter cubed, air cleaner minus 0.3, air cleaner and health coach minus 0.6, not statistically significant. So meaning that although we could reduce particles, we couldn't necessarily reduce everything that comes from tobacco smoke. So I think the important message here is if there's a parent of a child with asthma, getting an air cleaner could well be good. Symptom days improved in this trial in the people who got the air cleaners, but it's not as good as not smoking, and so it's not a substitute for not smoking. It's sort of the best intermediate thing you could do if you can't get the parent to quit smoking. One last one I'm going to show you is just another approach that we're taking and something that we've called the stove study. My colleague Nadia Hansel's running this. This is a HUD-funded study, and this we're looking to see if we can target NO2 in particular. It turns out that gas stoves in Baltimore City are very common. They're almost never vented to the outside, so they produce the fumes and particles in the home. And so we have a trial going on right now that where we're looking at homes with an unvented gas stove, and they're being randomly assigned to get a substitute stove, which is an electric stove, or put in a vent that vents the gases outside, or to use 2 air cleaners. And the study will finish December, so I don't have the final results yet. But it looks like, at least for the 1 week, the immediate effect is that that swapping the stove out makes good sense. It's source control, but there might be an advantage to the air purifiers because that also might mop up NO2 that isn't just produced by the gas stove, but from other sources as well. Those aren't final results yet, but it's sort of the early peak at the what happens immediately. So these are approaches we're taking to sort of thinking about interventions and ways to improve the environment. So I'm going to finish there. I think we do questions, which I hope you'll send in if you're online after Kate goes. And so I'm going to turn this over to Kate.